Good afternoon, everyone. The topic for today's class is topical fluorides. Introduction. Dental caries is a major dental disease impairing the quality of life, posing heavy financial burden on public health services. Fluorides, they play a pivotal role in prevention of dental caries. They have karyostatic efficacy and causes decline in caries prevalence. So coming to the introduction of fluoride, it is a trace element, member of halogen family having atomic number 9 and atomic weight 19. Sources is the dried fish and tea. It is present in rock and soils as fluorspar, fluorapatite, and cryolite. It is distributed in atmosphere, soil, gaseous industrial waste, and also emitted in the volcanic areas. So mode for administration is two, systemic fluorides and topical fluorides. So we will talk about the topical fluorides. So this is the flow chart. Coming to topical fluorides, we have professionally applied and self-applied. Professionally applied, we have the paste, solutions in sodium fluoride, stannous fluoride, gels, and varnishes. And self-applied, these are the dentifrices, mouth rinses, and gels. This we will talk about in detail. So first coming to professionally applied topical fluorides. First, we have the fluoridated prophylactic paste, which was first started in the year 1946. Stannous fluoride, we have active fluoride. Zinc silicate, which is abrasive. Prophylaxis, we remove the outer fluoride layer. For the prophylactic paste, it replenishes the lost fluoride layer with a small gain in the concentration of the fluoride. In aqueous solution and gel, the first and the principal vehicle in which the professionally applied topical fluorides were available. They were very time consuming. In 1960, gel products came, which include solution plus hydroxyethyl cellulose in the form of the gel. Advantages is that it adheres to tooth for a considerable time. Two or four quadrants are treated simultaneously when trays are used. Accidental ingestion of large quantity is not possible. Thixotropic solution have high viscosity and fluoride uptake is similar to the APF gels. Coming to sodium fluoride, so it is the first topically applied fluoride compound. It is prepared by dissolving 20 grams of sodium fluoride powder in 1 liter of distilled water in plastic bottle. In glass container, it reacts with the silica, so free ions are available, so we do not use glass container. The name of technique is known as the Knudsen technique. How we do the application for the fluoride solution. Firstly, oral prophylaxis is done. Then isolation with cotton rolls. Teeth are dried thoroughly. Fluoride solution is applied and allowed to dry for 3 to 4 minutes. Three further application is done at 1 week interval and it is used for the age group of 3, 7, 11 and 13 years. The mechanism of action, the principal compound formed is calcium fluoride due to high concentration of the fluoride. Choking of effect is important because once a thick layer of calcium fluoride is formed, it interferes with the further uptake. So sodium fluoride once applied is left to dry for 4 minutes. Advantages is that it has an acceptable taste and stable if stored in plastic container. Disadvantage is that frequent visit to the dentist is required for a month. Next is the stannous fluoride. It is freshly prepared before it is used. Commonly used as 8% concentration. For preparing, 0.8 gram is dissolved in 10 ml of distilled water. Immediately applied, the technique is known as Muller's technique. Remaining is discarded and it is applied once in a year. For Muller techniques, there is single application technique. First, we do oral prophylaxis, then isolation. Teeth are dried. Solution is applied and kept moist for 4 minutes, repeated in the remaining quadrants and repeated every 6 months. For mechanism of action, there is formation of the stannous fluorophosphate, which prevents the phosphate loss. It reacts with hydroxyapatite to form fluoridated hydroxyapatite, and it makes the tooth surface stable. Advantage is that once a year. Disadvantage is that it has to be freshly prepared, has metallic taste, can cause the pigmentation. Next is the acidulated phosphate fluoride was discovered in 1960 by Brudewals, also known as Brudewal solution, prepared by dissolving 20 grams of sodium fluoride in 1 ml of 0.1 m phosphoric acid, to which 50% hydrofluoric acid is added to make the concentration at 1.23%. The gelling agent, it is the methyl cellulose or hydroxyethyl cellulose. The pH for that is 4 to 5. Mechanism of action, it is applied on the teeth. Dehydration and shrinkage in the volume of HA crystals and the formation of the DCPD is done. Dicalcium phosphate dihydrate is highly reactive with fluoride and leads to the formation of the fluorapatite. For the application, there is a paint-on technique, and for gel, tray technique is there. Oral prophylaxis is done. Teeth are isolated, dried. Fluoride is applied repeatedly for 15 to 30 seconds with the help of the cotton applicator and kept moist for 4 minutes. Not allowed to eat, drink, or rinse for 30 minutes. Applied at 6 to 12 months interval. Advantages: only 2 application. Deposit is there, stable, and full mouth can be treated. Disadvantage is that acidic and bitter taste cannot be stored in glass container. Next is the fluoride varnish. That is, Durafat was the first varnish formed in Germany. It is a viscous yellowish material, has sodium fluoride concentration 22.6 milligram of fluoride per ml. Difluorosilane ethyl difluorohydroxysilane is the agent that is being used. Next is fluor protector. It is also a fluoride varnish which uses polyurethane lacquer dissolved in chloroform and difluorosilane at concentration of 2% equivalent to 3.2% fluoride in liquid. It has a better depth of penetration and concentration in the enamel surface. Technique: we do oral prophylaxis, dry the tooth, no cotton rolls, apply on the upper arch first, then on the lower arch. 4 minutes application time, not allowed to rinse or drink for 1 hour. No solid till next morning, and it will have 18 hours contact. Limitation is that it has a personal cost and difficult in areas with the shortage of dental professionals. So we have the self-applied topical fluorides which are brought and dispensed by the individual patient. A low concentration of fluoride is provided, 200 to 1000 ppm, available in form of dentifrices, gel and mouth rinses. So dentifrices, it requires active participation by the patient. Different types have been recognized. In 1955, so stannous fluoride first recognized by FDA, then 1964 accepted by ADA, 1942 clinical trials were there, and BB gave sodium fluoride as an active agent for the fluoride dentifrice. So composition, we have abrasives, humectants, binders, surface active agents, flavoring agents, and the sweeteners. The fluoride compounds that are used in dentifrices are sodium fluoride, stannous fluoride, monofluorophosphate, and amine fluoride dentifrices. The fluoride mouth rinses that are being available, was given by BB et al. In the year 1946. It includes neutral sodium fluoride, acidulated phosphate fluoride mouth rinses, and stannous fluoride mouth rinses. So sodium fluoride mouth rinses available at 0.2%. Weekly use gives 900 ppm of fluoride, or 0.05%. For daily use gives 225 ppm of fluoride. For the preparation, we use 200 milligram of sodium fluoride tablet in 5 teaspoons of fresh clean water. The concentration can also be given at 0.04% of the sodium fluoride. Next is the acidified sodium fluoride mouth rinses, which is available in the concentration of 0.01% sodium fluoride solution, which gives 45 ppm of the fluorides. Next is the stannous fluoride mouth rinses. So it has the anti-caries activity similar to the sodium fluoride. It uses ammonium fluoride mouth rinses can be there, or amine fluoride mouth rinses can be there. Next is the fluoride gels. So in the form of the gel, we can use the neutral sodium fluoride having 5000 ppm concentration. Acidulated phosphate fluoride also has 5000 ppm. Stannous fluoride 1000 ppm. Applied in trays, or it can be brushed on the teeth. It has certain advantages that for the home use, for the patient, more number of applications can be done, and it is not recommended for the children below the age of 6 years because they can swallow. Next is the topical fluorides, which can be applied. The advantage is that there will be prevention of lesion, and it will arrest and reversal of the incipient lesions can be done. So these are the basic types of the topical fluorides, that is professionally applied, which includes sodium fluoride, stannous fluoride, and acidulated phosphate fluorides. And second will be the self-applied topical fluorides, which will include the following. That will be the fluoride mouth rinses, gels, and fluoride dentifrices. So these are the references which can be used for rinsing of the fluorides. Thank you.